Just for folks on the phone, it's the meeting's really well attended. So with that, we can begin to do introductions. I'm Diane Feeney, and I'm with the Commission on the quality team. Dr. Butt, or I'm sorry, Noy, do you want to go ahead? Can you turn your microphone on? Hi, I'm Noy Reed. I'm with HCRC on quality.
I'm Dr. Zahid Butt. I'm CEO of Medisol, but I'm here in my individual capacity.
Hi, I'm Stephanie Clapper here with the Maryland Citizens Health Initiative.
And I'm Pat Ercolano with the University of Maryland System.
Trish Roddy with Medicaid.
Dan Cochran with Adventist Healthcare.
Tracy Laval from the Maryland Hospital Association.
Hi, I'm Fozzie Sabi with Mid-Atlantic Permanente Medical Group.
Linda Costa, University of Maryland School of Nursing.
Teresa Lee, Maryland Healthcare Commission.
Bob Murray, representing Care First.
Andy Zimmer with HSCRC.
Allison Schuster, HSCRC.
Shura Girovich, HSCRC.
Donna Kinzer, HSCRC.
And I think we may have people on the phone, so if you would please introduce yourself.
All right,
This is Matt Sweeney from Mathematical Policy Research.
Good morning, Matt. Perfect timing. So we have a full agenda, and first of all, I appreciate everyone who worked with us on the readmission reduction program. As you see on the agenda, we are going to go through the mathematical analysis of risk adjustment, and then MHA and Care First have some suggestions on the methodology for fiscal year 18. And finally, we have some updates on the measurement specifications that we would like input from you. And with that, Donna has to leave in an hour, unfortunately, so I would appreciate if everyone keeps their presentations to 10 minutes so we can have the discussion with her while she's here. Obviously, we can continue after she leaves as well. All right, with that, Matt, are you ready? Oh, so I have a few before he starts. So let's, before we go into the risk adjustment, I just wanted to give you an update on the trends on the CMMI target. So this chart shows cumulative change in readmission rate. The red one is the national Medicare trend, and then the gray one is the CMMI data Maryland Medicare trend. So this is kind of cumulatively, if you just focus on the December, so for the 12-month period, our rate of change would be at 2.18% based on the CMMI data, and the national number is at negative 1.01% for the 12th month. And what we are doing is we're just adding the month so we can get to the 12th month to see the trend. What you see here is our rate of decline actually is getting slower, right? When we looked at it in August, we were about 3% decline. Now, in December, we are at 2% decline. But what we discovered in the CMMI data, because they exclude rehab cases for the special license beds that we have in Maryland data, but not in the national data, because ICD-10 doesn't have, my understanding is it doesn't have specific codes for the rehab, so they are going into different DRGs. We are still working on adequately taking those out. We think that there is an error in the October, November, and December months. So that's why you're seeing a slowing down, because we have more readmissions for the last 3 months of the year. So what we did is we plotted the HSCRC trend at the bottom with the dotted lines. And here you see that our trend from the HSCRC data for Medicare population is around 4%. We originally planned to do some modeling and try to adjust, but you see the trends are not that parallel between the CMMI and our data. So we are still working through the data to understand the differences, but currently it looks like we will either maintain our progress or we may have some slowdown in the last 3 months. And finally, on the national data, the 4-month lag, this is with 3-month lag. So the 1% seems high to us, but with one more data, which is coming this week, we may have some update by May meeting. And if you just want to look at the readmission trend month by month, this is from 2013 monthly readmission trends. The one at the very top is HCRC Medicare readmission rate, unadjusted. And then the next one is the CMMI Maryland rate. And then finally, the last one is the national readmission rate. In general, as you see, the trends are parallel, but you see that change in September to December time period. So based on these numbers, I did quick target calculations. So the way that we are doing, I try to simplify it. Hopefully this will make more sense. So for the 2013 national Medicare readmission rate, we are starting at 15.39%, and the Maryland is at 16.6%. And the difference between the two is 1.2%. So if you take 1/5 of that difference, every year we have to have additional, we have to close the gap by 2.24%. So when you plug those numbers in for calendar year 15, so for calendar year 14, the difference between national and Maryland was supposed to be at 0.98%. So if we add that to the national one, our Maryland target should have been at 16.48%, and our actual came at 16.47%. So we barely made the target. Yay! But as you see, it's not because we improved too much. It's because national actually went up by 0.7%. So, we barely made it, yet it's not about our improvement. It's really about the national trend. So in the next two rows, I plugged in the November number and the December number to get us a sense of where we would be. If we use the November trend, which is now national, is declining at 0.55%, then our target is at 16.15, and we are at 16.10. So we are making, if we take the November trend. But if we take the December trend, we are not. So even though we thought that we have a lot of cushion, what I'm getting from this is it's really hard to predict the last 3 months of the year, and we should be cautious. We think we are going to make it, yet the cushion is not as big as what we thought we have back in December meeting.
But that's based on the data that we know there's a problem with, right?
Right. The November is not that problem, right? So that's kind of, in November there is some problem, but November doesn't seem that bad compared to the December trend. But you're right. Even in October, November, December trends, we think rehabs are impacting it. So that's why we think we are going to make it. However, I don't know what the cushion is going to be. Mm-hmm. So that's what I was trying to say. Because the worry I have is that our trend is not, our trend is stable. So we haven't, it's at 3% or at 4%, right? So it's continuous at 4%. So we'll either maintain the trend cushion that we saw, or it's going to deteriorate if the national trend is, because there's no problem in the national trend, right? Rehab and the national trend is the same. So this is the readmission improvement rate by hospital. As you know, 9.3 is the threshold. So again, 1/3, 1/3, 1/3 is still the same. That 1/3 of our hospitals are going to make that 9.3 threshold and receive additional revenue. And the rest of the hospitals have incremental penalties. And again, we have a handful of hospitals that we see a readmission increase in their rates compared to the calendar year 13 base. So we've been discussing the one option for the fiscal year 17 adjustments to use Medicare. What you have in this gray line is the Medicare improvement rates. So the reds are still what you saw in the previous slide, the all-payer improvement rates. And as you see, there is some variation in Medicare improvement rates, notably rural regional. If you concentrate on that one in the middle, the gray line, their all-payer improvement rate is much slower than the Medicare improvement rate. But then you look at the MedStar St. Mary's, the impact is opposite. So finally, we are going to continue the discussion on the base rate, the impact of the base rate. So here I have two lines. The first, concentrate on the gray line. The gray line is the calendar year 13 base rate for each hospital. And I try to make it so that the x-axis on the second, if you see 14 to 12%, so the x-axis is kind of state average. So any gray line above the x-axis is above the state average, and anything below is lower than the state average. So what you see here is the tail end, the ones that are increasing readmission rates, they're almost all of them are below the state average. So that's what we've been discussing, that they have low readmission rates, and their trend seems to be different than the ones that have high readmission rates. Then the, oh, where did it go? Then the other line, I think it's brown, is when you add the out-of-state to these rates, what you see is they're the ones who were below the state average is actually close to the state average because they tend to be in the neighboring regions of the state. So some of their readmissions are going to the other hospitals that we don't have in the data. So we estimated that using the Medicare data, we took the proportion of readmissions happening out of state and added back to the all-payer one as an approximation. And as you see, for the other hospitals, there's not much change when you add the out-of-state readmissions. So with that, I'm going to turn it to Matt.
Okay, sure thing. Can you hear me okay?
Yep.
All right, thanks, Shuley. My name is Matt Sweeney. I'm a senior health researcher at Mathematica, and we've been working with Shuley and our team over the last few months on a number of issues. And today I'll be presenting some of our preliminary results related to our work on the risk-adjusted readmission rate and regression-based readmission rate. Next slide, please. So the basic overview here is that what we're really interested in is in testing the impact of adding additional covariates to the model to predict readmissions for the hospitals, basically building on the current case mix. The current approach is basically, which is based largely on case mix. But the first thing we want to do is that we want to convert the current approach of indirect standardization to more of a regression-based approach. That would really facilitate the addition of additional covariates like age and gender and comorbidities to the model to assess their impacts. So basically the first stage is to take the current approach and convert it to a regression-based approach. And then once we have that in our hands, we can then go ahead and test the impacts of adding additional covariates to the models and assess things like the impact on the model fit, impact on hospital rates, the impact on hospital improvement from calendar year 2013 to calendar year 2015, and you can see on the slide the covariates that we tested: age, gender. We tested the Elix-Hauser comorbidities, which is similar but slightly different than the Charlson comorbidities, primary payer category, and then finally ADI. Next slide. So I think everyone's probably very familiar with the current approach and how readmissions are predicted for the hospitals through this indirect standardization approach. There's a calculation of the statewide readmission norms for each of the APR, DRG, severity of illness categories, and then hospital-level predicted readmissions are calculated based on the relative frequency of those APR, DRG categories and the statewide observed rate for those categories. To take that current approach and turn it into a regression framework, it's actually fairly straightforward. Really, what you can do is run what we call a fixed effects regression, an APR, DRG, SOI fixed effects regression, which mathematically yields the identical number of predicted readmissions as the indirect standardization approach. it's a stay-level regression, so each observation of the regression would be an individual stay that qualifies, that meets the inclusion and exclusion criteria. The dependent variable would just be a 0 or 1 indicator for whether or not that stay resulted in a 30-day readmission. And the independent variables, well, there'd be a lot of them. There'd be a 0 or 1 indicator for each of the over 1,000 APR-DRG categories. So the pros of this approach is that it facilitates the assessment of the explanatory power or the predictability of the current approach. We can now, using the regression, either we estimate the regression, look at things like the C-statistic and the R-squared to assess things like the predictive ability and the amount of variation that are explained by the model. And once we have that in hand, it's pretty easy to then test the addition of additional covariates to the model as well, as I discussed. The primary con to this is that this fixed effects regression with all 1,100 of these variables in it is computationally intensive. It takes a while to chug along. There's some collinearity issues with some of the APR-DRG dummy variables. So with that in mind, that's a primary motivation for looking for maybe a simpler approach, a simpler model that yields very similar results to the baseline or the current approach. So next slide. So the first thing we do is we have kind of honed in on what we call a norms-based regression. So rather than running a regression where we have 1,100 variables on the right-hand side of the equation, we're going to run a regression where we have just one variable on the right-hand side of the equation. And we'll replace those SOI indicators, APR-DRG SOI indicators, with the calendar year 2013 norms as a single variable. In a way, this is sort of like, if you think about an APR-DRG weights, which is calibrated based on cost and resource utilization. This would almost be sort of like an APR-DRG that's calibrated to readmission as an outcome. Just a small note, we noticed that if we took instead of just using the norms themselves directly in the model, if we took the natural log transformation of them, it fit the model a little bit better. It's just a minor note there. What I'll show you in a minute is that this norms-based approach actually yielded almost identical readmission rates, adjusted readmission rates for hospitals. It has performance that is basically the same as the current approach in terms of predictability and explanation of the variation. So once we have that in hand, then it's much easier to test the impact of adding additional covariates. So as I mentioned before, we'll test the impact of patient age and gender, the Alex-Hauser comorbidities, which are 31 indicators for various conditions. We calculate that that's an algorithm that we ran on the data using the information on the index stay. So I just want to point that out, that we're flagging a patient's comorbidities based on the information that's present on that index stay. We'll also test whether or not there are impacts like for controlling for primary payer, and the broad payer categories are shown here on the slide. And finally, we're going to test for the impact of patient socio-demographic status as proxied by the area deprivation index, which I know you're familiar with as well. Next slide. All right, thanks. So just quickly we'll talk about the data and methods. So we used calendar year 2013 and calendar year 2015 inpatient data provided by HSCRC. We're running regressions here. Each regression is going to be estimated using a logistic model, and we're estimating that model over the calendar year 2013 stays. And then based on the estimation of the regression and the fitted coefficients, we're then going to calculate for each stay the predicted probability of a readmission. We're going to do that both for the calendar year 13 stays as well as the calendar year 15 stays. And what this means is that the calendar year 15 predicted values are benchmarked to calendar year 2013, which is in line with how the current approach that's being used. After we run the regressions, we're going to measure the R-squared and the C-statistic. The R-squared is just a measure of how much variation is explained by the model. The C-statistic is a number that tells us how well does the model predict readmissions. The C-statistic of 0.5 would actually be a pretty poor number. A C-statistic of 0.5 would indicate that the model is doing no better than a coin flip in terms of predicting whether or not a readmission occurred. A C-statistic closer to 1 means that there's greater predictability of the model. And a C-statistic of around 0.7 is a rough threshold or benchmark for saying that there's adequate predictability of the model. Once we run these regressions, we're going to calculate the hospital-level readmission rates, and this is pretty similar to how it's done currently. Across all the individuals of stays, we'll calculate the sum of the predicted probabilities we'll then calculate the observed over expected ratio, where the expected number of readmissions is the sum of the predicted probabilities. We'll multiply that ratio by the state rate in 2013 to come up with the risk-adjusted rate. And then finally, we'll calculate the percent improvement between 13 and 15 for each hospital. So that last part should be pretty familiar for everybody. Next slide. Thanks. So here are the models, the summary of the models that we're going to present today. I'll note that we ran a bunch of different models. That's why you see in that first column that we have up, the number of models is up to 20. I've excluded a lot that we just sort of decided are not good candidate models. So here, the first row shows the baseline model. This is the model where we include all 1,100 APR, DRG, SOI indicators. This is the regression-based version of the current approach. So we're going to use that as a baseline. And then we have model 15, which is on the second row. This is using the norms. Instead of using all those 1,100 indicators, we're going to use one singular variable, this sort of APR, DRG weight as it's calibrated to readmissions, and that'll be the only covariate in the model. And then we see models 18, 19, and 20. We just build consecutively on what's in model 15. So model 18 controls for age, gender, and the comorbidities. 19 controls for those as well as age, gender, comorbidities, and payer. And then finally, model 20 is the fully adjusted model that also includes controls for ADI. Next slide. So here are some of the model statistics from the regressions. So I'll start with the first row on the baseline regression. So again, this is the regression version, regression-based version of what's currently being employed. The C-statistic is 0.712, which is actually a pretty robust C-statistic for a readmission model, and the max rescaled R-squared is 0.128. That might seem low, but that is actually, compared to some of the other readmission R-squareds I've seen in the literature, that seems to be a pretty robust number. So that's actually explaining a fair amount of the variation. Turning to model 15, again, this is the model where I'm going to argue that we've come up with a simpler model that achieves something that's very close to baseline. You can see that the C-statistic and the max rescaled R-squared are almost identical to the baseline model. Moving to models 18, 19, and 20, you can see that as we add covariates to the model, the C-statistic and the R-squared are increased slightly. They are improved, but I wouldn't say there's any dramatic changes in the C-statistic or the R-squared from adding these additional covariates to the models. Next slide. So I apologize. This probably looks completely tiny on the screen in front of you. These are the estimated covariates from the fully adjusted model. So model 20. This is all the covariates included in the regression. A couple things to note here. All the coefficients here represent conditional correlations, meaning that the interpretation is sort of the marginal association of a given covariate, all else equal. Since we're controlling for all these other things simultaneously. And also just note that for some of these kind of groups of covariates, we have reference groups, and they're noted on the slide. So the interpretation of a coefficient is sort of in relation to that reference group. By and large, you can see that the county year norms, county year 13 norms at the top there have a very strong impact on readmissions as expected. You see some of the comorbidities. Some are statistically significant, others are not. There could be a bit of a collinearity issue here across some of these individual comorbidity indicators. It's also possible that there's already a lot of information contained in the county year norms that we're controlling for a baseline. And then finally, ADI, I'll turn to so it's on the right-hand side of this slide. You can see that really you start to see the impact of ADI on the probability of readmission at the higher quantiles or I should say ventiles of the ADI distribution. So patients from areas in the 85th, 90th, 95th percentile of the ADI distribution are much more likely to be readmitted to a hospital than compared to those at the lowest percentile or lowest ventile of the distribution.
So Matt, sorry to cut you off. Just in terms of the way you look at the odds ratios, if you look at the Medicare payer, just to give you an idea, compared to the commercial population, Medicare fee-for-service patients have 42% higher probability odds of getting readmitted. So that's so the numbers above 1 is higher probability. The numbers below is lower probability.
Yep, that's right. Thanks for pointing that out, Sheila.
It's Albert. A question?
Sure.
Can you go back to the previous slide? So, you know, when we're looking at your norm-based models, which start with maybe it was 15 or something like that.
Mm-hmm.
So that is I'm wondering what the assumptions are there. Are you assuming that the APR-DRG SOI is going to be stable from 2013 to 2015? Is that what? Is that one of the assumptions?
Well, it's in terms of it's setting a baseline here for what's expected for that APR-DRG SOI for calendar year 15. So yeah, I guess there is sort of an assumption that is going to be the case.
So my question is that if I were a hospital and over a period of years, if my you know, it's APR-DRG adjusted SOI changed quite a lot, what would be the implications of using this approach as opposed to one which had every single, you know, APR-DRG very inefficiently in the model?
Can I answer that quickly? So the norms are based on expected rates. So if you have heart failure statewide, the expected readmission rate is the average state readmission rate. So let's say 10%. So, and if the hospital is changing their number of heart failure patients in next year, then their expected number of readmissions is going to be based on how many patients they have. So the difference between fixed effects versus norms is just mathematically they produce the same thing. One is just computationally, you know, faster than the other one, because when you put the fixed effects, you're still trying to predict the average expected readmission for each APR-DRG and SOI level.
Yeah, maybe I would have to understand better exactly how those norms were calculated.
Yeah, we can take that offline if you don't mind. Maybe after the meeting we can talk about the specifics of the math.
Yeah, I mean, my only, you know, it's certainly possible that case mix over the next 5 years will be changing for all of the hospitals. You know, hopefully more people are staying out of the hospital. That would change the proportion of, you know, people with various diagnoses and severity who are still hospitalized. And so I'm, you know, I just want us to be mindful of making sure that what we do creates the right incentives and doesn't penalize people for pushing, you know, for pushing more, keeping more people in the community.
Right.
Okay, this slide here.
Matt, sorry, Dr. Barr has a question.
Yeah, hi Matt. I just have a question. So in the SOI, which is flowing through in every model, much of the sort of weighting is based on essentially comorbid conditions. And so when you add the comorbid conditions again, are you kind of double counting comorbidity in that sense in the modeling?
Well, I think I'll frame it a little bit differently. I think what we're seeing is that there's already a lot of information captured by the APR-DRG SOIs. For example, you brought up comorbidity, I'll bring up age. You know, age is one of the factors that assigns a stay to a particular SOI category, for example. So what we're seeing is that we're not seeing a lot of impact of adding these additional covariates in the model. I think in part because there is a lot of information already sort of packed into the APR-DRG SOI categories, whether it's the individual indicators or if we're using the norms. I think a lot of the information is already captured by those, by that set of variables.
Thank you.
Yeah. Okay, so I'm on slide 17 now. So what we've done here is we've calculated in calendar year 2013 all the hospitals' risk-adjusted rates and then estimated a correlation matrix across those to see how much impact there is on hospital rates from using these various models. So I'll just concentrate on the first column here, which basically compares the baseline model versus all the alternate models that we estimated. You can see that model 15, which is using the norms instead of the SOI or the APR-DRG SOI indicators, is strongly correlated with baseline 0.999, meaning that on average, almost, well, I shouldn't say they're the same, but there's a very strong correlation between the baseline and the model 15 results. I'll show you in a moment that they're almost identical when we estimate it that way. As you move down, you start controlling for additional covariates. There is some impact on some hospitals' rates. That the correlation starts to decrease, but I'd say overall it still remains fairly strong. Even in model 20, which has the lowest correlation, has still a very high correlation in absolute terms of 0.91. Next slide.
Yeah, I want to point out the correlation between, so model 20 is ADI, right? That's the difference only between 20 and 19. And the correlation between the two models is 0.99 as well.
That's right. Yep. This is a very similar table, but this is calculating the improvement rates, calculated over the 2013 and 2015 rates that we calculated. Again, very strong correlation in the improvement rates across the models. Next slide. So this is showing plotting the calendar year 13 rates from the baseline model versus, sorry, let me back up. That's not what I'm saying. This is the percent improvements that we calculate using the baseline model that's plotted on the horizontal axis, and the percent improvement using model 15, which is the norms-based. And we plotted those, and we plotted the 45-degree line. You can see that basically every hospital is along that 45-degree line, meaning that the improvement rate calculated between baseline and calendar 15 really isn't impacted at all by converting to that simpler model. This is comparing baseline to the fully adjusted model, model 20. You can see here that there is an impact on hospitals' improvement rates, and the main takeaway here is that for the most part, for almost every hospital, improvement is lower. The rate of improvement is lower when you adjust for all the covariates and ADI in the model. Next slide. This graph is showing you one cut of what the impact of adjusting for ADI is. So what we've done here is for each hospital, we calculate the percentage of patients that are in the 85th or higher percentile of the EDI distribution, and arrayed that from left to right. So hospitals on the left-hand side of this graph have a lower percentage of patients from highly deprived areas, and then hospitals on the far right of this graph have a higher percentage of patients from highly deprived areas as measured by the ADI index. And the graph here, the line, is showing the difference between the model 19 and model 20 rate. So model 19 controls for all the covariates except for ADI, and model 20 controls for ADI. And you can see that the general pattern here is somewhat expected. Hospitals on the left have, once you control for ADI, have a slight increase in their readmission rate after controlling for ADI, about 0.2 of a percentage point. But I think probably more interestingly, on the right-hand side of this graph, the hospitals, for the most part, hospitals have a higher percentage of their patients coming from high ADI areas have an improvement in their readmission rate, or actually a decrease in their readmission rate once you control for ADI, upwards of 0.6 of a percentage point. Next slide.
I plotted it differently, the same information, but here what you have is the APR-DRG model compared to the full model. So the blue ones are APR-DRG model that we currently use, and then what you see is the red, that for some hospitals it's increasing their readmission rate, and for some it's decreasing. And if you look at the Bayview, Midtown, Mount Secure, their readmission rates are coming down, and I think from the face validity, that's what we would expect, and that's what's happening with the adjustments. So what I did is trying to compare the impact of each model one by one. So this is the base model for APR-DRG. And when you add the age, sex, and comorbidities, the change is happening for the same hospitals that we see. When you add payer, the change is not that significant. And finally, the red one is the fully adjusted with the ADI. So if you look at the Montgomery, Fort Washington doctors, majority of that change is happening with the model 18 when we add the age and other factors. So if you think about building the models, the majority of the impact for the hospital readmission rate is coming from the age, sex, and comorbidity adjustment, and we are still working on the collinearity issue, so that these are all preliminary. But from the face of it, it looks like a lot of the issues are adjusted if you add those three variables. ADI has an impact at the lower end, but not as much as the age, sex, and the comorbidity, it looks like.
And part of that would be because the ADI is associated with higher comorbidity. So if you actually measure comorbidities, then you're taking some of the impact of, you're taking it out of calling it ADI and putting it into medical terminology of what's actually happening to the patient.
And finally, the improvement rate that Matt showed. So this is the improvement rates. Reds are all payer improvement rates, and the gray is when you fully adjust and then calculate the improvement rates. So what is happening is for hospitals who had increases in their readmission rate, when you adjust it, their increases are actually higher, right? The gray line is above. And then for the declining hospitals, their declines are lower. So what you saw as the impact improvement rates getting smaller is happening only for the hospitals that have a decline in their readmission rate. So this, we need to think about what it means, but this is not expected. If you think about the improvements happening for the low-hanging fruit or some of the easy ways, here we are adjusting for it, right? If you are doing targeted interventions for transportation, for elderly, we are controlling for those factors, so then the differences are not showing up once we adjust for the differences in readmission rates.
So the conclusion is that all of the statistical analysis just makes the improvement look a little worse. In terms of the absolute measure, there are some differences, but as far as the improvement, it looks a little worse for almost everybody in the state when we do all these regression adjustments.
Just because I'm trying to, does that make sense in the sense of, because obviously our ability to impact the other populations is what we're recognizing. Is that, am I thinking of that correctly? When you're saying, when we adjust for that, it makes it look worse.
So, like, if you think about expected rate, right? So here there is an expected rate for low deprived areas, and that's standardized at, let's say, 2%. So in both time periods, we're saying your expected has to be 2%. And if you're reducing your average readmission rate, and if that's 2%, let's say you are doing it 1%, the model is still telling you that your expected is at still 2%. So you're not getting credit for reducing the readmission rate for that particular cell. And it does make sense to us that what you're seeing is, I'm not sure about why it's getting worse for everybody. So we haven't looked at in detail exactly how the impacts are playing, but in general it does make sense to us. And from our policy perspective, we were concerned, one of the staff proposals was to adjust the target and we hold the hospitals harmless if they had high readmission rates, because we were concerned that we were going to put them at a higher disadvantage if they were serving the low deprived areas, high deprived areas. So what it's showing us, actually, maybe it is not true. If you adjust for it, their readmission improvements are smaller. So I think here what it's showing is that we could expect higher improvement rates for hospitals who have disadvantaged populations, because we are not adjusting for it.
if I could just ask, what's the implication for the staff recommendation and the policy of this? And how do you plan to incorporate this or not incorporate this into?
So I think we could do a more linear target calculation, given that the impact ACS is as expected.
You could do a
linear. So we hold the 9.3 at the state average. We could make it higher for hospitals who have higher readmission rates. Right. Our reason for not increasing the target was because we were concerned that we will put them at a disadvantage.
But it's 9.5 is the cumulative, correct?
Right. 9.3 is last year. So if you do the same for 17 too, I think that could go up, because what we are seeing is that hospitals with low disadvantage, with disadvantaged populations have higher improvement rates. If you don't control for ACS, you could expect higher improvements. If you control for ACS, then you would have lower readmission rates.
But so, I'm sorry, I know you get moving with this, but in the staff recommendation, you scaled the % required reduction for the hospitals that had readmission rates, base year readmission rates below the statewide average. Now you're suggesting have that scaling be more continuous.
Right. Better said, I guess.
I guess the original question was, did we need protection on the other end because there was an unfair disadvantage to hospitals with high readmission rates? And as far as improvement goes, the answer is no. And you know, then it would be a policy question of whether you actually wanted to raise the targets or you didn't want to raise the targets for people who had a lot of patients with ADI. Certainly, we definitely want to improve the readmission rates for people with high ADI, because that's consistent with our goals of reducing health disparities. But so I'm not saying that that's what we want to do with the policy, but at least we are seeing that we don't need to protect the improvement rate. When we get to the attainment issue, we're looking at the baseline comparisons of one hospital to another, then there's a slightly different picture. But as far as improvement goals, there's no reason to protect the hospitals that have high readmissions due to ADI, and in fact, we do want to actually have a lot of improvement to help us with the health disparities issues.
This is Tracy. A couple things. First, I just want to commend you all for this work. It's a lot of really detailed work, and it's presented very clearly. It's things that we've been hoping to see and wanting to see, so just really appreciate all of this work. A couple of questions that I have. One, when we look at slide 24 and looking at the APR-DRG model, is that the norms as we currently use them? Like, is that what we're currently looking at?
Oh, actually, I'm not sure, but they are the same.
Right. What I'm thinking back to is if we're looking at percentage change and we update the norms in the policy, I think back to the earlier questions about in this modeling that Mathematica has done, we use the 2013 norms, but yet when we look in the policy, we update those norms.
No, we don't. Right? We don't.
They stay the same the whole time?
Yes.
But we rerun those base periods.
No, the base is fixed on 2013. Norms are based on 2013.
A change in measurement, we would.
Right. Right now, since we are doing a cumulative improvement norms and the base rates are 2013.
Okay. Okay.
Yeah. And the regression exactly did the same thing, but rather than doing cell by cell, they just did it on the regression.
Yeah, that part I got. I misunderstood completely. I thought that the norms were updated each year.
Not for readmission.
Okay.
Because we're looking at a cumulative improvement rates.
Okay. Well, that answers my question then. And then the other piece that when we were talking about implications, I'm having a harder time following the conversation about the change and that after adjusting for all these factors, that rates of change can be expected to be lower overall. But then I think we went on to this idea of they could have expected, rates of change could be expected to be higher for certain kinds of hospitals, and we didn't need to protect other kinds of hospitals. And I'm not following all of that right there. I didn't see that laid out, and I'm not following how we got there.
So I guess what I'm seeing, and maybe people can tell me whether I'm wrong, but doing all of this statistical, our APR-DRG model works pretty well as is, without adding a lot of regression on top of it. It's doing a pretty good job. These are mostly fairly small improvements in the APR-DRGs, so they're performing pretty well. If we go to just measuring improvement to say, well, did any of these models change how much a hospital would have been measured to improve on slide 24, basically the results that I see here is that every hospital would have done worse on the improvement except for Bon Secours, who actually did better with this model, but every other hospital on these charts did worse in terms of having a percentage improvement. So it's not, and they're mostly pretty close to each other. So it's a lot of regression analysis adding complexity to the model, but it doesn't really give us a different answer as far as who improved, except for a tiny bit for Bon Secours. But the rest of them are actually a little bit, nobody's getting a lot better as a result, a lot different and more positive improvement result from adding all the complexity.
Right. If I can just pause a second, I understand all of that. My question was not that. My question was when we went on to say that it's not necessary to protect certain kinds of hospitals from how much improvement they should be expected, or when we should expect more improvement for other kinds of hospitals. That's the piece where I wasn't following that in what was presented.
So basically, if we look at hospitals that have high ADIs, they're not having a negative, or they're not getting a positive impact from adding all of this regression analysis in their improvement targets, in their improvement results. So, yes, the whole graphic shows that they're not, with the exception of Bon Secours getting a fairly tiny amount, that they're not getting better on improvement by adding all of these. They're not improving more when you add all of these regression factors. So they're not getting relief because of adding all of these regression factors into the formula. At least that's how I'm looking at it and interpreting it. So it's not, the regression factors aren't helping anybody from an improvement measurement standpoint, except one tiny bit for Bon Secours, which
but I guess where I'm still stuck is this is just their performance. So to me, when we were looking for these additional factors to help explain readmission rates, it wasn't so much to explain how much improvement they could expect, but where their readmission rates, their attainment rates.
Right, and so that's a different answer and a different graph, but on the improvement, it doesn't make much of a difference.
Right. If we keep the staff recommendation as keeping it as an improvement and adjust the targets based on base year, calendar year 13 readmission rates, we were concerned initially not to increase the targets for hospitals who were higher than the state average, with the assumption that they were taking care of low, high ADI people, right? We felt that we were going to increase the burden on them unfairly because they had high readmission rate. So we agree that they have high readmission rate, but when you look at the improvement rate, what Donna is saying and I'm saying is you don't need to protect them because improvement rates would have been lower if we adjust for the ADI.
I follow you now. We had a different starting question. So that's where this comes in, is that I was coming from the assumption that this was, one, we are looking at these more for attainment, and then I think we haven't gotten to that part yet. And then to me, the second question was for hospitals that have lower starting rates for whatever reason, do they need to be protected from having the same amount of improvement expected of them? And that piece I don't think we're answering or speaking to with this.
I think what we are saying is that if there is a relationship with the base rate, and if the hospital has low readmission rate and the expectation is that they are going to have slower improvement, the same applies to the ones that are on the other end, right? So I think what the commission at the meeting also alluded to our inconsistency in terms of rationale. If we are saying the base rate impacts the improvement rate, it impacts across the board. Staff concern was the ACS impact, and this graph is telling us that we are not as concerned looking at this, that there needs to be a protection for the high end of the rate. Pat?
My only request for the staff is to consider, so it makes all sense of what you're saying. I only want to comment on the speed to improvement. So that if, in fact, the staff would be considering perhaps a harder, more aggressive target for those hospitals with higher rates, I would just ask consideration the fact of we still need to implement strategies over time for that continued decrease.
All right, so MHA and Care First proposals are next. Who would like to start first?
I propose we do them at the same time.
Flip a coin or run a regression. Okay.
Doesn't mind. I can go next. You have the slide.
Slide deck. Oh, okay.
So I'll just start as we pull those up. That our policy objectives matched well with the commission's, I think, to evaluate additional variables that would impact readmission rates and try to explain more of the variation in readmission rates. So I'm just trying to go a little bit quickly, so I won't talk to every slide.
Do you want it? I mean, I can follow her as she could. And unfortunately, we couldn't make the time. So Donna,
and I am leaving, but I did want to just make one comment in terms of approaches. In terms, if we're changing approaches, there's a lot of work between a new approach and now, and if we were changing approach, it would take months to complete something. That doesn't mean that we can't consider protections, but I just want to make sure that we understand if we're changing approaches that will have impact on timing.
Yeah, so your comment makes it sound like there's not an opportunity to make any change besides a tweak to the current improvement only.
Well, I just want you to have a full discussion about how much time it would take to change anything, and as you go through the meeting, so that we have a realistic assessment of what would happen and then how it would affect timing of other things. So that's all I'm saying is let's talk about timing in terms of processes.
Right. So those are really important points, and of course they're important to the hospital field also. So we have considered those as we've gone along, and that has shaped what our recommendation has come to. And I think you'll see as I go through this that for us, our most important objective was to include an attainment approach. And so really, when you have an attainment approach, the risk model is a separate discussion. So there are, you all laid out, through the work that Mathematica has done, there are several different risk models that could be applied to any attainment approach. For us, I think we want what everyone wants is a risk model that works well and that is statistically sound and makes clinical sense. So maybe as you consider what we put forward, the thought is for this group to consider and for the commission to consider that how big of a leap is it really to add an attainment component. So I think that's where I'd like folks to think about from what we put forward.
And also, I wish I actually were here because I wanted to be here to hear the presentation, but in terms of some of the out-of-state issues and other things that we have to deal with, of being able to tweak the model to consider some of those things as well.
Yeah, and we put that into our model.
And good. But yeah, so I think just about, adding attainment at the one thing is for next year, another thing is for this year. So if we're trying to add something looking backwards at the end of the year and we haven't had a chance to do full analysis, that is maybe a challenge. So I want to have a discussion of that, and also just to say that it's not, we're not looking at it to impact our other policies. It would just be focused on this one particular policy.
So yeah, I'm not sure exactly what that means.
Right. So
this is we're thinking of this for readmissions, not for anything else.
Right.
And again, I hope that we really do have the opportunity to consider this, because your comments again sound like we may not.
I just want to make sure that you all have a thorough discussion about the impact on timing. So and to do something prospective is one thing. To do something retroactive is a whole different thing on timing. Because
could I propose that we talk some more about this later, because I don't know exactly what those comments mean.
Well, I just want you to bring it up in the meeting and discuss it fully, because if you're saying let's change how we measured readmissions last year.
No. This is for calendar 16 measurement. That's what we're talking about, 16 measurement.
We need to do both, right? Because I think if you're identifying a problem, we need to do some adjustments for calendar year 15 measures that we discussed in the last meeting. That's not going away, I believe.
Yeah.
And then if you're proposing major changes to 16, what Donna is saying, we are in April, May, so we need to think about, okay, if we all agree that we're going to do this, what is the timing of finalizing this policy? And we think from the staff perspective, it's not May. We have only 2 weeks left actually I have 1 week left to write the final recommendation. So if that's the case, what is the realistic time to work out the details and finalize the policy? So that's a discussion we want to have.
Right. So if this is for calendar year 16, then do we want to have a staff report in June or July meeting, not in May meeting? And if we're going to do anything with 15, it can't be something that we can't get done until June or July or August, is I guess what I'm saying.
Yeah. So what we were thinking for 15, looking back, was really, taking to heart some of the comments that were raised earlier of that policy's done, it was settled, no major changes to that policy. So our recommendations were more tweaks to that. So setting that aside, we're focused more on calendar 16 and adding an attainment component to that. And I think you'll see that what we propose is pretty straightforward. And then the question of which risk model to use, that we're much more flexible on. Whether, one option is to continue to use the norms as they are, not change that risk model at all. Another is to use a different model that includes more variables. Because like you say, for, they're very similar. I think hospital-specific, there are more differences, and there definitely is in the hospital field a desire to move to a model that includes other kinds of variables. But we're more flexible on that risk model, but we are more concerned about getting an attainment component for 16.
So then
we are concerned about the model because it has to be fair to everyone. So I can't, we've been saying the APR-DRGs are doing a good job, but we said that it's not suitable for ranking, right?
Mm-hmm.
So I do think that if we are changing it, that we need to make sure we do a good job with the risk model.
So the way that we address that is by including both attainment and improvement.
All right, let's go through it, and then CareFirst has a different risk model, I would say. I think they are handling it differently, so I think we could have that also put into place.
So thank you. So it's really just, if we're going to change something and making sure that we put an adequate timeline in place to do it.
Mm-hmm. Agree.
Thanks.
Yeah, agree. Okay, so I'll flip onto page 4 or slide 4. So all payer, unplanned 30-day readmissions as we measure now. We do include an out-of-state adjustment, and we do that based on the Medicare data. So again, the percentage of readmissions that happen in-state to out-of-state to in-state. And for most hospitals, that's pretty consistent, but for each, like for 13, we adjusted the hospital's 13 rates by their 13 Medicare data, 14 by their 14 data.
Tracy, could I just ask, so the source data are Medicare data in and out of state?
Yeah, it's Medicare claims.
So how did you get that? I mean, that was directly from CMMI, or?
Yes.
Okay. So that's publicly available data, is that?
It's not publicly, but it could be available to those who are modeling the readmission model.
I see, okay.
So just
that would account for only the Medicare out-of-state, right?
It does. So, I mean, that's a good point, that we're adjusting all payer readmissions and risk-adjusted readmissions, but that's what we had, and that's what we had.
I'm sorry to belabor this, but on that point, I mean, I think theoretically you could get Medicaid data and you get CareFirst data, and you'd have.
Yeah, theoretically.
Yeah. Well, I mean, I don't know about Medicaid, but CareFirst could provide that information, I think, yes, but whatever.
I did ask for total cost reports from the private payers 2 years ago, and I wasn't able to get it, and we're still working with our contractor to get it from the all-payer database. Yes, theoretically, yes, if you want to go and add it to get it. And the Medicaid files, long time ago, I worked with the fee-for-service claims to look at that when we were looking at the episode, and it requires a lot of cleaning up because I think it is doable. If we think we should do it, then we should add it to the timeline.
Yeah. I'm not suggesting we do this tomorrow or whatever, but I'm saying it's something that could be feasibly done in a year.
We should put it on our timeline. Right.
It could possibly be advantageous to you.
Yeah, we tried to get Americaid data, and we also have potentially Kaiser data. Dr. Fazli Sabi's here, and Holy Cross is a border hospital, which may have a lot of leakage into the district or Virginia, so that could be helpful.
So it might be helpful if you are doing readmission analysis as private payer to look at that issue and give us some estimates. Before we do more analysis, we can just compare by payer what that out-of-state readmission distribution is to feel more comfortable using the Medicare numbers.
So, Shula, you alluded to some sort of computation that you did based on some Medicare correlation. Was that sort of taking the Medicare trend, comparing it to sort of an all-payer, or maybe I misunderstood when earlier you were referring to some analysis that you did, that you said the out-of-state was adjusted?
Yeah, so I think it's a similar method with MHA. What we are doing is we're taking the proportion of readmissions happening out of state for Medicare.
Right.
And then if it is 3% more readmissions, we're adding that 3% to the all-payer
So there's
number.
a mathematical way of potentially trying to adjust for that.
Yeah.
It's using the Medicare experience and extrapolating that to all.
Extrapolate to the all.
Right.
Okay. So I'm on slide 5 now. And just a couple concepts here. Attainment, that's the score based on a hospital's risk-adjusted performance relative to a statewide risk-adjusted target. And improvement would be the hospital score based on their risk-adjusted year-over-year performance. And then we use the final score as the higher of or the better of attainment and improvement, like is done with MHAC and QBR and other national programs. So then we come to the point of, so once you have an expected rate and you're looking at the risk-adjusted rate, how do you translate that into some payment adjustment? And I mentioned, and I think we talked about at the last meeting, QBR, MHAC, the national policies, they use the threshold and benchmark and the 0 to 10 points. But readmission rates, their range is really wide. It ranges over 10 percentage points. So trying to cram that big range of readmission rates into a 10-point scale does mean that when you move from, say, a score of 3 to a score of 4, there's a big gap in how much the readmission rate changes. It also leaves hospitals on the low end and the high end generally either getting really high scores or getting really low scores. So we worked with that model, but we've discarded it since then. So this is, we have one, this is the, I guess you call it the measurement construct that we would use or suggest, and it's pretty straightforward. So we would just compare the hospital-specific risk-adjusted rate to the statewide risk-adjusted target. This is the attainment piece. And so that statewide risk-adjusted rate would be the target rate or expected rate for each hospital. So again, this is where we assume then that that risk adjustment is working well enough to say this is the target for every hospital. We know that that's not exactly right because the models aren't perfect, but having that piece and the improvement seems to balance out and make it a more fair approach.
Clarification, so the statewide risk-adjusted rate is the average? So it's the same for all hospitals that you're comparing how far they are from the average statewide risk?
Right. And the average that we used was wasn't like add up each readmission rate and what's the average, but it was what are all taking
hospital.
Yeah.
So not weighted for their discharges.
Well, actually it is. So it would be just looking at all of the numerator is all of the readmissions, the denominator is all of the eligible cases.
Did you all consider the ABC benchmarking methodology to account for some of these issues in terms of not having to take the state average but to have a higher benchmark?
The ABC.
Yeah, it's the activity-based. I think CMS is proposing to adopt that in some.
I'm not familiar with that.
University of Alabama developed methodology for benchmarking.
Yeah, I'm not familiar with that. But then if you go on to slide 7, this is just how we would look at what we would translate to the payment. So on the left side is the attainment scale. So if a hospital were, for example, in the green, 3% below the target or the statewide average, then their payment adjustment would be a positive 0.25 or their score. Then they would also be judged on their improvement. So then you look over to the improvement side, and let's say the hospital's improvement was 2%. So a 2% improvement would translate to a 0.15 positive payment adjustment. So taking the better of those two, the hospital would be getting a 0.25 improvement, getting a 0.25 payment adjustment. And likewise, if the hospital was above their target readmission rate by 3%, down there in the pink on the left side, they would get a negative 0.25 payment adjustment. And if their performance declined by 2%, also in the pink, then they'd get a negative 0.15. So their adjustment would be a negative 0.15.
So on the improvement scale, your base is 0 improvement. So if the hospital improves, they get positive, and if their readmission rate increases, they get a negative, right? You remove the improvement target concept from this?
Right. No improvement target. Just does their performance go up or down?
So then how do you balance this discussion about the improvement rates might be different based on your attainment? So you're seeing you're dealing with attainment over here, improvement, the stick is still the same for all the hospitals as
right. And so that's why we chose the better of, because thinking that a hospital that had, and we see it borne out in the data, that hospitals that tend to attain their rates don't have as much improvement.
Mm-hmm.
And vice versa. Because we also tried doing the net of the two, and it just seemed to multiply either the penalty or the reward without really differentiating.
So I'm sorry, just to make sure. So you use either the attainment or the improvement?
They get judged on both, and then whichever is the better of is their final adjustment.
So if you are to get the same amount of adjustment, you either have to be like let's say 1% improvement, right? You either have to be 1% below the statewide average, your readmission rate, right? Let's say 1%, you are 1% below this, or you have to improve by 1%,
right? And
you get the same revenue adjustment,
right?
But how would you define what is the better of?
Whichever one is so in that case it's the same.
So if you are 2% below the average, then you get the 2%, even though you improved by 1%. So they are equating the distance from the average to exactly the same as the improvement rate.
Right. That's right. And that was how we balanced them. Saying that.
So the adjustment column is what would be looked at and see where somebody would fall, right?
Yeah. Yeah. Maybe it would help. I have. Let me pass these around.
Yeah, it might help with the actual.
So here we go. So I'm passing around some modeling. This is modeling calendar 13 and 14 data, and one side of the paper looks at using just the norms. The other side of the paper does the same modeling using the norms plus some additional variables. So if we look at the side that uses the risk-adjusted rate compared to the risk-adjusted target, attainment and improvement, and then in parentheses HSCRC, APR, SOI norms 13 to 14. So this is just using the current norms. And what we have is the first column is the calendar 13 HSCRC risk-adjusted rates with that out-of-state adjustment applied. The second column is the calendar 14 risk-adjusted rate, again with the out-of-state adjustment applied. The next column says, you can see down here, it says this column C is the target is 13.13. So we're comparing the 14 rate to the 13.13, the target. And you can see the first hospital at the top, Garrett County, they were 32% under that statewide target. Then the next column says, okay, how does that apply to the attainment scale? Garrett's a tough one to use because they're always going to be so far below that. But they would be outperforming the target by more than 20%. So they would do the 2% positive adjustment, looking back at that pink and green. Then the next column is the improvement. So this is just looking at the 14 rate compared to the 13 rate. So Garrett's improvement from 13 to 14 was 12.4%. That one for them is a positive payment adjustment of 1.22, and you can see how that relates on the right-hand side of that orange and green chart. And then their better one is the attainment, so that would give them the positive 2%. So then I think what we looked at was in looking at, does this feel like an appropriate model, is how are the scores, do we see a nice array of adjustments at the end? We wouldn't want to see a lot skewed to one end or the other.
So it seems to me it's skewed to the positive. My first look at it. So you have 1, 2, 3, 4, 5, 6.
That was seven that are.
Sorry. So is that because we have a lot of improvement, or is it because we are comparing to the average state?
I think it could be either one. I think it could be either one.
I think it's really going to depend upon what that benchmark is. That's where I was getting at. If you leave the benchmark really low, it's going to skew in this way. But if the benchmark can be higher, it will be different.
Yep. And so that brings the question of what is that appropriate, is statewide average? What's that the appropriate one to use?
Yes, and our answer is state average is higher than the national average.
Right. And so, but I think sorry, I'm not disagreeing, but I think what I want to point out is I think that this approach is pretty straightforward, pretty clean, and you have some levers to use if you want to, adjust this a bit. You can use a different risk model, and you could certainly have a debate about what that appropriate target would be.
Just on that point, talking about levers, how does this fit? I mean, we've intentionally picked a 9.5 cumulative reduction target because we want to, hit a specific goal. What's the lever here to, if we find we put this in place and we are not improving assess? Is there a joystick that we can use to, similar to the 9.5, which is maybe not a joystick, but you know what I'm saying? What could drive this, like your current policy where you have the 9.5 and you could actually increase that or decrease that depending upon how we're doing?
So, I mean, would that, I was thinking that too. So it's departing it from that idea. So the only way I think we could do is, the performance scale would be based on that 9.3 still. That you get positive only if you improve better than the performance target. And I think that, I think the question is how do we make sure we hit our CMS target?
So I would answer that question in this way, in that the way to do that is to change what the target is or the benchmark is. We're using the statewide average. And the reason I say that is because if you have a target for both, then we're back into the same conundrum that we are now, is that it doesn't appear that every hospital has that same opportunity to improve, that those are different. So both of those need to be baked into the methodology.
Right, but whether you have a 0, right now you have a 0 improvement, or whether you have a 9, it's the same issue, I think. So I don't.
So I would disagree a little bit, because if you improve 0, you get a 0. So let's say that my readmission rate is 15%, and that's above whatever. It's above the statewide average, so that's above whatever. So I'm not getting points on this attainment side. So then when I look over to the improvement side, the only way that I can avoid a penalty and get some positive is to improve. And if I improve, you know, I've got to work on that improvement side to get some positive. So that's the incentive for those hospitals.
Right, for CMMI though, we have to improve more than 0, right? If I am, on the other hand, if I'm lower at if I'm lower 2%, or what, then I don't have any incentive to improve, because I'm going to get my money from the attainment, right?
Well, you can, if you're, let's say my readmission rate is 13%, and the target is 13.13. So I'm outperforming the target, but barely. So if I will outperform the target more, then I'm going to get a more positive payment adjustment. So the incentive is there. It really is magnifying the global budget incentives, but it's balancing both attainment and improvement to have some of both.
Yeah, I mean, it could do it in one or the other, but I do think that we need to find a way to add that CMMI target question and incentivize lowering the readmission rate. I'm not sure. Right now, if this is the case, yes, in the middle, people have incentive to do things differently, but in general, if this is my baseline scale, how do we incentivize improvement, right?
So you would have a huge incentive. I'm not advocating this, but
yeah.
But say you put that that benchmark at 8%, ridiculously low. But if you put that there, that's a huge incentive for both. Right. And what it means is that it doesn't add in that kind of artificial 9.3% by improvement, because not everyone has that same ability.
You could take the 9.3 and put it on the attainment, reduce the state average by whatever the.
It's left to right.
Yeah, it is.
Well, you could. Sorry.
9.3 or 9.5. It gives you a goal that you are shooting for, and it's based on your analysis of where we are, where we need to be. Whereas this is okay, where you have to change that benchmark up or down, and you're not exactly sure. It just seems less direct.
Yeah, I mean, another way to think of it is to say, what does the statewide average readmission rate need to be to meet the Medicare readmission test?
And you could put,
yes, Albert.
and you could put that wherever you want on the right side of your risk-adjusted rate to target. You could plug that in, and it doesn't have to be. It could be that you're still plus 1%, and you still might get a reward if that target was set really, really low.
But I think one way to, again, sort of get around is to see whether that is an achievable target, and to use that sort of methodology to see the highest performing cohort within the sample is able to produce a rate that is achievable for the state.
It would be nice to have an example of like the two, like base rates and the improvement rate, and how that 9.5 or how it will impact different hospitals. So I think, you know what I mean, like if you are putting your target at whatever the required reduction is, and then to look at the behavior and the math, right? If I am far above, if I improve by 3%, I'm still getting a reward, even though I'm not going to help moving the achievement. So I think we kind of need to think about individual. It's nice to have the example, we need to look, but also think about, okay, if the target is 10% readmission rate, and I'm at 17% already, I'm still going to get incremental money for any any improvement that I make, yet we may still not achieve that overall 9.5% improvement statewide. So I think, you know, we need to think more how this relates to how we can ensure, basically, we would have the improvement rates that we need. Because I'm afraid that with this, you may give more credit to the attainment and reduce the incentives for improvement regardless. And then you give a lot of positive incentives for any improvement between 0 to 10, 9%. That is not going to be enough for us to achieve.
Well, you can't reward everyone. You know, if some people, you know, hit on attainment and some people hit on improvement, you know, everyone could theoretically win, but that, you know, wouldn't work out financially.
Right. So in the improvement, for example, if you look at the scale on the slide, 10% improvement now is associated with 1% positive adjustment. In our current scale, it's 0, almost 0. Right. So, like, the current approach is really focused on improvement, and this approach is trying to mix it together, but it seems to me heavier on the attainment side, unless we do something with the target to make it also some improvement built into the attainment portion of it too.
So I think conceptually I like this approach because it is really driving people towards achieving a goal. But it would really depend upon, again, I think, which has already been discussed, what that attainment level is. Because if the bar is too low on the attainment side, it won't work. So the bar needs to be much higher on the attainment side. So that's where the key is going to be, what is that achievable goal that achieves that thing, so that you are actually rewarding people who have achieved that goal, but those who are working towards achieving the goal are being rewarded somehow. So I think conceptually that makes the most sense, but how to sort of factor in all these various needs is really, how you draw that attainment number is really going to be the key.
And just one last point on that, I think you alluded to it too. We're high as a state, so you know, what's demonstrably achievable shouldn't be just limited to looking at Maryland performance. We should look outside the state to high-performing states also.
Yep.
Yeah, I just wanted to throw in that maybe if we really want to make sure that we're incentivizing improvement, it doesn't necessarily have to be perfectly balanced like this in terms of how the payments work out. The overall cap on the kind of adjustment you can get for attainment could be half of what you could get by improving. So even a hospital that's already beat it still has that incentive. You know, they could sit and do nothing and get a 1% payment adjustment, or they could improve by 15, 20% and get an increase.
All right. Do you want to finish?
So slide 8 really just says the 2 risk models that we looked at and modeled. As I was saying earlier, I think that's for a broader discussion. And
Tracy,
yeah?
Can I interrupt real quick?
Yes.
It might be a good time to ask the question, because we did have a good bit of conversation around which risk model to use at the hospital level, and the HSCRC with their vendor has modeled a risk approach, which isn't, you know, drastically different than what's here listed as the hybrid model. And you did, when Donna was here, you alluded to looking at a graph on attainment using those results. So it sounded like you already have done some work applying that risk model, not just to the improvement that you showed this morning, but to attainment. Can you either comment on that or share that with us after the meeting?
Yeah, so I'll go back. Oh, it's not in this slide. But if you look at your package, that I tried to show the impact of the models, but let me just point out the chart. Let me find it. So it's it doesn't have slide 22 after 21. Do you see 21? The risk adjustment readmission rate calendar year 2013. And the red one is the fully risk adjusted rate, and the blue is the APR-DRG case mix adjustment. So you do see that the ranking will change slightly for some hospitals. So, for example, right, so the Garrett, we talked about Garrett. Garrett's rate is going to go up a little bit, but it's kind of an average change. So it's not, Garrett is still our best performing readmission hospital. Setting aside, this doesn't have the out-of-state issue, right? Once you add it, they change it a little bit. Yes. Right. So once you risk adjust and ADI adjust, then they look worse. And then the bounce curves look better, but they are still the highest readmission rate hospital. And the risk adjustment, this is a preliminary analysis. I'm still not sure, because what I noticed is all the Baltimore hospitals are over here, and I'm not sure what to make of it yet. We did the patient level analysis now, and we're still working on it, but this kind of, despite the adjustment, I think they are still going to be the high readmission rate. So is that the hospitals, or is it something about other things that we are still not controlling for? So I do, you said you are you are flexible on the risk adjustment. I am not. I'm sorry, but I really cannot. I don't think we can afford. But
to change or to stay the same?
I mean, like, we need to find the right model to do it. If we are doing attainment, we need to ensure that we are, APR-DRGs are doing a good job, we all agree, but then for specific hospitals, it may be different. Maybe if you add the improvement at the end, it may not be, look, I just feel uncomfortable without looking data and understanding it to just say, yeah, we could kind of use any risk adjustment and we'll be fine.
So to get at what Justin was, I think, alluding to, is you've done the risk adjustment model as more to kind of look at the impact on improvement,
right?
But not to incorporate an attainment component to the RRIP at this stage. Okay.
Right. I was waiting for your proposals first to start working on something else. And these numbers came to us last week, so it's not like we are sitting on it. So we are going to look at it, but the issue is, in my perspective, to look at that regression model a little bit closely to see if it's still doing a good job or not. Do we need to add other things? Do we need to remove things?
Yeah, so I'm not sure where it fits into today's conversation, but I do think it would be helpful, since the work looks like already done, to not only take slide 20.
You want the numbers?
But this is on calendar 13, has a change for calendar 15, and then do a similar, correlation and some of the other analysis that you did on the improvement side, on the attainment side. I think would be great for the hospital industry to have that information and start talking about it, because we are thinking about a risk adjustment and what does it look like and what are the benefits, and I think this would help further that conversation. So.
Right. So I think some of those, math presented are there too, but I just find it easier to look here to see the impact. You could kind of look at the numbers, but Suburban Holy Cross, that is expected to me that their risk-adjusted readmission rate is higher than what we have in the case mix, right? Suburban, Holy Cross. But the issue I'm struggling with is ADI doesn't have as much impact, and maybe because we are adjusting all the comorbidities already. So all these ideas about ADI impact is not showing if you look at the next slide where you have a lot of colors. But basically, the jump is happening once you move to model 18 with age, sex, and comorbidity. A lot of the difference is coming from there for Fort Washington, that group. Then you look at Suburban Holy Cross, yeah, you do see some differences there, but still they are marginal if you think about the range here is, 13 to 11%. So I think we would like to investigate this a little bit more if we are moving in an attainment and kind of look at the impact. The complication is it worth the squeeze, right? So I think whatever model we are looking, we need to model all the way through and to see really if there is an impact or not, or whether we can accommodate a less sophisticated risk-adjusted model.
And I think I would say that that probably goes back to the earlier conversation that Donna raised about timing.
Right.
And that's why we say we have more flexibility on the risk model, because looking at models that incorporate other variables, it looks like it does a better job of explaining readmission rates, and that the impacts for particular hospitals are meaningful. But as we get down to this, time to fish or cut bait, then if it comes down to the point where we don't have the time to do as much investigating of the full model as we would like to, it would be our preference then to say stick with the norms, but add this attainment component. Even though it's not perfect, we're not doing just attainment. If we were, that would raise a lot more concerns about using just the norms. But by using a model that incorporates both attainment and improvement, that gives us that little bit of buffer and comfort level, because we're used to the improvement using the norms.
All right. Any other questions on the MHA method?
So, Shule, I know complexity was mentioned several times, and would it be too complex to replace the indirect standardization with regression and just add the couple of variables that you mentioned seem to be driving a lot of the incremental difference for some of the hospitals? Mm-hmm. They seem to be clustered around Suburban and Holy Cross for some reason. There's divergence there, and then the 4 or 5 on the right-hand side seem to diverge a little bit in some of those things. But other than that, the ADI, you're correct, doesn't seem to add as much as we may have anticipated based on the earlier data that we saw. But would it be easier to sort of take the risk, the SOI, essentially indirect standardization, and use the regression model, because it looks like it perfectly replicates that.
Right.
And then you can add a couple of more variables like the age, and the primary insurer, I think, seems to make a difference. And whether you use ADI or not may, be left for later on, but certainly it would account for some of these variations that we're seeing in here. So I don't know what the feasibility of that would be in terms of how much of a change that would entail.
I mean, I believe I think the issue is hospital improvement folks are used to looking at side by side and looking at the expected rates, and it means something to them. And it's straightforward. As we do a regression analysis, it becomes harder for them to understand where their risk-adjusted readmission rate is coming from. I mean, from the analytical perspective, it is doable. We do have regression on mortality that we kind of have calculation sheet basically to compute that, but I feel it's harder from the quality improvement perspective. So that's where the trade-off comes in. Yeah. But ADI, I think I agree with you a little bit on that one to see. Or I don't know right now, if you take all the age, sex, comorbidities and just put ADI, what is that? We haven't looked at it, and that's what I'm saying. We have some more work to do on the risk adjustment. But what will be helpful is, Tracy, if you model 20 versus case mix through your model and then see whether the impact change. Because you're saying, I think that shouldn't take too long for us to just see, at the end of the day, if you include attainment and improvement, case mix adjusted versus fully adjusted, is the final impact. And if it doesn't show that much of an impact, maybe then it won't be too long for us to change it. Bob, your turn.
Thanks, Shulik. I'll try to step through this quickly, and you can click.
Do you want me to click, or?
Yeah, why don't you click? I'll just tell you how to do this. What we tried to do was address dilemma that staff encountered in the RRIP recommendation of trying to reflect or take into account a hospital's base year attainment level as they impose the 9.5% percentage reduction. And then in going through the logic, are you going to have my paper up there? Oh, that's okay. Okay.
There's slides.
I mean,
which
the
looks
slides are
like
hard
your
enough to
paper
read.
too.
If you want, I could read the whole thing. No, but I'll try to step through the slides. In fact, you have the hard copy, so we hardly even need that up.
And you have a copy in front of you.
Yeah, right. So the purpose of the first slide was to say we're trying to fit something into the general construct of staff with the RRIP recommendation. We also thought there might be an opportunity to combine elements of the shared savings with the RRIP. So that's kind of the overall goal. Slide 3 just talks about what we saw as a dilemma facing staff. I think it's a fair presumption that hospitals that have low base year readmission rates, high attainment levels, might have a harder time improving at the same rate as a hospital with a much higher readmission rate. So I think that was a fair point and a reasonable thing to try to address. But at the same time, the staff noted that it's hard to really truly assess hospitals' attainment level because you're not adjusting for some of these other factors. So, on the low end of the spectrum or the high end of the spectrum, there are probably these variations. So you can't necessarily say, hospitals 3 and 4, they're low, but they're equal because one may have, socioeconomic factors affecting them or out-of-state readmissions that are also affecting them. So it's not a precise evaluation that you can apply. And we also thought that not applying some sort of adjustment for hospitals that are high was maybe unfair and a little bit, and you've kind of addressed that issue now. So maybe go to the next slide, slide 4. We thought we could borrow from policies that the HSCRC had used before in addressing similar issues. Our bias is to use the data and the case mix data as much as possible. Look at the results by APR, DRG, SOI. That's, I think, what the industry is used to, as opposed to regression models. I personally feel like anybody who does a regression model, maybe Mathematica should have a license, because it's a tendency to default to regression analysis, and it is black box, and there are multiple variables you could throw in. And then at the end of the day, you see it's not that much different than the current methodology we have, which is better understood, I think, and at least from my standpoint, it's a preferred approach for the system. But what we thought was, previously in the context of the Commission's disproportionate share methodology, we tried to adjust for hospital costs that treated higher proportions of quote indigent patients. We had a methodology where we looked at different payer classes that could be associated with a lower socioeconomic index: Medicaid, self-pay charity, and also Medicaid secondary payer, which is usually the dual population. And if you could separate out the data into two cohorts, an indigent cohort and a non-indigent cohort, and then take a look at the readmission rates statewide to see if they were demonstrably different, then maybe that would be a way of getting at this issue of socioeconomic status in calculating hospitals' readmission rate. So not only would you case mix adjust, that is, look at what the hospital's readmission rate would be if they had the statewide average readmission rate by APR, DRG, SOI, but you could also indigent adjust a readmission rate for a given hospital. So it's the idea of kind of combining those two elements. So the first test would be, say, is this a relevant approach? Is there a demonstrable statistically significant difference between the readmission rate of the indigent cohort and the non-indigent cohort? If so, then maybe you can move forward with the rest of the analysis. And there are various examples that I have in here. Maybe turn to page 5. We also had this, this desire on part of staff to try to address this issue of attainment, the point I mentioned at the beginning. And so in that regard, we thought we could borrow from a current policy of the HSCRC, which is the uncompensated care policy, where prospectively every year the HSCRC puts a provision in hospital rates, and that provision is a blend of the hospital's actual uncompensated care 3-year moving average and a more standardized calculation. It is a regression, unfortunately, but it does result in a more standardized statewide estimate of what is a reasonable level of uncompensated care. So you're blending what you know about the hospital's actual performance with what is sort of a standard that could be applied to that hospital, and then basically taking 50-50 blend of that to create what we've referred to as a standardized or a baseline standard for the hospital. And for hospitals that had favorable actual readmission rate experience relative to their case mix adjusted, indigent adjusted readmission rate, they would actually get cut a break on this methodology, because we're proposing keeping the 9.5 cumulative, applying it to everybody, not scaling it in various ways. But this methodology would cut hospitals that had a favorable actual readmission rate performance relative to their case mix indigent adjusted standardized approach a break. And likewise, hospitals that had an unfavorable actual relative to the case mix indigent adjusted readmission rate, they would have a target that was more challenging that would be applied to them. And so I won't go through in detail, but on slide 8, there is an example where we just took a hospital, just kind of picked these numbers. Yeah, keep going forward, Shule. There, that one. So this just says, okay, a hospital has an actual readmission rate of 10. This case mix indigent adjusted standardized readmission rate is 12. There's baseline standard, the figure that you're applying the 9.5 to see how much they should come down is the blend of those two, which would be 11. So we apply the 9.5 times the 11, and they have to come down to their new target now is 9.955, which is actually very close to their actual. So in this case, the hospital will come down a very trivial amount. It reflects their actual performance, and because it's more favorable than their standardized readmission performance, the methodology cuts them a break. So it recognizes the fact that on an attainment basis, they're doing relatively good. And likewise, we have a couple of other examples. A hospital who has an actual readmission rate of 12, a case mix adjusted standard of 10, and so this creates a more challenging target for them to meet. So it tried to get at some of the issues that staff was trying to address. On slide 10, there's a kind of a complicated figure here, but it shows the blend of the actual and the case mix and indigent adjusted readmission rate, and then how the 9.5 would be applied to create a new target, and then you'd compare that to their actual. On table 1, slide 11, I then do 3 different case examples. A hospital that has a favorable performance, that's case 1. Case 2 is a hospital that has a less favorable performance. And then there's a third, a very highly favorable performance where the hospital's actual is way below its case mix and indigent adjusted standard. And you can see in this case, they would actually generate not an offset, but a reward.
Can you walk the case 3 for us?
Yeah, so the hospital's actual is 9.
Right.
They're standardized, which includes case mix and indigent adjusted, 12. So the baseline standard is 50% of 9 and 12, which would be 10.5. And then you would subtract off, you would look at the 9.5% adjustment to look at how much additional they'd have to improve. And their new target is on line 8, which is 9.5. But the hospital's actually at 9. So they're doing better than their target, and so they either would have no penalty, or you'll see in the later part of this presentation, I'm suggesting combining this approach with the shared savings approach, where you offset amounts in rates. But in this case, because of the highly favorable performance of the hospital, they actually get some additional money in the context of the shared savings.
So their favorable performance is coming from the indigenous adjustment only, right?
No, well,
Where is
their
that coming
statewide
from?
average, their case mix. So the 12 is at the SOI level. That's what their readmission rate would be if they had the statewide average at each individual cell, as well as factoring in this indigent adjustment. And there, in Appendix 1, there is just illustrates a hospital with 3 different DRGs. I broke it out into an indigent cohort and a non-indigent cohort just to show how it would be calculated to get that standardized amount. So we're looking at their actual, when I say actual, unadjusted, yes. And I'll have to talk with you because the staff recommendation was a little confusing on that point because you refer to risk-adjusted, case mix adjusted.
They're all the same.
But then you also, in one of the exhibits, you refer to actual. And so
actual is actual observed, and whenever we say case mix adjustment and risk adjustment, we have just case mix adjustment. I apologize for the confusion.
Yeah, okay. Well, so I have to sort that out with you, but the idea would be to look at their actual as one parameter in this.
I mean, similar. I'm confused, frankly. If you think I'm confusing, I am confused too at this point. If you are going back to the actual, are you still comparing actual to the observed, like what we have, the expected versus observed?
Well, I have to sort through with you your formulas because those aren't 100% clear to me in terms of how those apply. But what I'm suggesting here is create a standardized readmission rate, which is at the hospital's readmission rate if they had the statewide average readmission rate by APR-DRG SOI. But also enhance that by doing an analysis that factors in indigent readmission rates if they're higher, and the distribution of a hospital's indigent cohort and non-indigent.
So if we translate that into our terminology, your 12% here is our expected, based on state average, right?
Yeah, I think.
Your 9% is observed.
It's their actual.
We say actual observed.
Right.
And then what you're doing is you're changing your.
What we're doing is we're creating a statistic that reflects their performance, their actual performance, relative to a case mix indigent adjusted standard, and applying that 9.5% cumulative reduction to that statistic
To
come
the
out
expected.
to the blend of the actual and the expected, or that you. So you understand the 12, right?
Yes.
Okay, the 12 is, I guess, your methodology, but it includes an indigent case mix standard as well, because I'm breaking it into 2 cohorts.
Yeah. So
Okay.
that's a new. So basically, you're creating a new expected.
Right.
And you're differentiating indigents versus not.
Right. Then I compare that to. Then we've also got the hospital's actual, and that's an indication of their attainment.
Right.
But we don't know exactly because it's not adjusted.
Right.
So now I'm taking a blend of what is a proxy for attainment, but then I'm taking a blend of that with something that adjusts for these 2 factors, case mix and indigent.
Mm-hmm.
And then that creates a new standard, and I apply the target against that new standard. And so in the case of case 3, the new standard for them, baseline standard, is 10.5. We apply the 9.5 cumulative reduction to that. They have to come down 1% from their. So the new target is in this case 9.5 because you apply that to their baseline standard. But effectively what it does is it cuts hospitals a break that are doing well on their actual readmission rate relative to what you would expect they would do if they had statewide average experience.
So
isn't the net of this to really dilute the risk adjustment essentially? Yeah. That's what it does. It sort of adjusts it first, and then it combines it back with the actual and sort of takes away that adjustment factor, because you're averaging out the actual and the risk adjusted number, and you're basically creating a new number that's not fully risk adjusted in that sense. So you're kind of taking halfway the risk adjustment part.
And so we'd have to, when you're ranking hospitals, we'd have to understand better what your statistic was. Quite frankly, it was confusing, and you did refer to it in different ways. And that one example in one of the appendix, you actually called it actual. That's what was.
Actual is always actual. Actual is observed.
Okay.
Actual is actual.
All right. But what we're trying to do with that actual is use a statistic that is reflective of attainment and factor that into the analysis.
But see, I think the purpose of risk adjustment is to take the observed and adjust it, and that's used for the attainment.
So
but I think what is happening here in this formula is that you're first risk adjusting, then you're adding it back into an average of the observed and the adjusted, so you're really taking back the adjustment a certain degree. That's what's happening in your column here. So you're taking the 9 and the 12 and you're making it a 10.5, which is in between the two. So really the adjustment was a 12, but you're taking it back because you're now creating an average between those two.
But the intent was to reflect that hospital's, where their position was relative in their base year.
The observed is always reflected in the risk-adjusted number because it starts from that. Now you can quibble with what the risk adjustment factors should be. Does it adjust a lot, or does it? And that's what we've been talking about, whether ADI adjusts much more than just the SOI plus the comorbid condition, so forth. So at the end of the day, you have to factor all those things into the number, and that's what you use for ranking and for benchmarking and whatever you want to do. I mean, that's conceptually, that's what I'm seeing happening here.
Yeah, it's Albert Wu. So, I mean, I think that this is an interesting, approach. I think it does acknowledge the fact that, that we don't understand all of the variables that we are using all that well. I think the area deprivation index is conceptually great. When it was applied, maybe the results were reassuring just in the last analysis, or maybe not. But the fact is that sort of no one has ever tried to build a readmission model starting from zero. We've always started with things that we understand, severity of illness, DRGs and so forth, which were never intended to predict readmission. They were measures of work in the hospital. So, it is possible that this approach, which is looking at indigent patients, that particular variable may wind up in the end being more promising. There are also other variables that are not, which perhaps relate to complexity, which are currently not being reflected adequately in some of the some of the results that where Hopkins falls out make it at least seem like there's some variables that might not be adequately taken into account. So I do think this is interesting.
That would be potentially one of the arguments to use an approach like this, is that we don't have full confidence in the risk adjustment, so we're going to use the observed for half of it, and for the other half we're going to adjust. Kind of that's what it tries to do. That this
and there's confusion around
not adjust the whole thing. It says I'm going to adjust some,
right,
but I'm not going to do it all the way.
That's essentially what this tries to do. I think
would it help if we say unadjusted readmission rate? Is that clearer?
I think, well, maybe. I just think if you could carry through your examples that you had in the paper to show what you use, that would be helpful to us. And then maybe there's an alternative to unadjusted or actual that could be used as that first variable. So it's the ranking of the hospital attainment, because that's what we're trying to do, is pick up a ranking of the hospital's attainment and compare that to something which is this more standardized risk adjusted but enhanced beyond just using the APRD or GSOI, and then creating a statistic upon which you apply the 9.5 and then uniformly apply the 9.5. So not scale it arbitrarily.
In a sense, you could create 3 columns. One is the unadjusted, the other would be fully adjusted, and this would be...
And 50-50. That's what he's doing.
That's what you're doing.
Right, and on the
third in between.
On the adjustment, there is an additional factor for indigent.
Yeah, right.
Right.
That's implicit in that ADI is the indigent stuff, right? So with maybe some primary insurance component added to it.
I guess, our bias is to just more use the case mix data because it's there. It would be representative of where there might be differences.
The question would be, how do you define indigent?
Right.
And so one way is to make the primary insurer, certain categories, and add the ADI, the social demographic factors.
That's one.
Right.
We were suggesting just
So I
doing.
think that would be a different discussion. It would be applicable to both scenarios. But in essence, conceptually, I think your proposal is that perhaps we don't understand enough about the fully risk-adjusted, whatever factors we in the end decide that need to go in.
Yeah, it was
with or without the ADI or other risk, indigent factors, but that not fully go to that model, whatever is decided, and have something in between.
Right, but you are also diminishing the case mix adjustment with this too by 50%, right? So you're cutting everything by health, and
but you're trying to get at different things here. That's the point of it. Your dilemma was we couldn't really assess attainment because we don't have these adjustments.
so the question I have is why then not use the fully risk adjusted? Why are we blending with 50-50? That's I'm not. If we are seeing the indigent population have high risk for readmission, why are we blending it 50-50?
Well, because I don't know if that gets at this issue of attainment. In the actual versus the standardized, you are having a recognition of the fact that a hospital has 10 actual or unadjusted and a standardized amount of 12 has favorable performance relative to what they would do if they did just the average of what every hospital did statewide.
But I think what Chule is saying is that why even adjust the 12% downward? Why are you splitting the difference? Why not just keep the 12% since that's our current best guess anyway?
How do you then factor in? You're saying then just adjust the 9.5 for how they rank? I mean, I'm trying to get at this issue of how they are ranking. And hospitals that are low arguably have a harder time improving by the full 9.5. So this approach tries to recognize that and adjust their performance to the fact that they're low. That's the point. That's the point of blending in these two.
I think that we're making a little bit of mistake. If someone's readmission rate is 6, I think we're not asking them to continue improving by 20% every year.
We're asking them all to continue to improve by 9.5%, whether they're 6 or 18. That's the dilemma, I think, that you were trying to address in the staff recommendation. And this is trying to address that dilemma. That's the point of this. So I know we're sort of running out of time. Do you mind if I just get to the last part of this, and then we can obviously have additional discussion. So if you go to slide 16, we also suggested, we really like the shared savings approach. I think it has a lot of merit because it prospectively offsets, an admittedly arbitrary amount of money every year, ties it minimally to readmissions, but we think it creates the opportunity of combining the prospective approach using the shared savings with this new methodology or this proposed methodology in the RRIP. And it could enhance the amount and the fairness of the shared savings offsets by what, and I have an example here on page 16. If you look at case 2, the amount that the hospital B has to come down could be quantified in terms of revenue. A percentage, you take the percent that they have to actually come down by, which is, in this case, 2.45, it's line 11. And if they had $20 million of readmission revenue, you can quantify that. In this case, it's about $500,000. There would be a $500,000 offset prospectively as a shared savings adjustment. So it would, and then likewise, if there was a hospital that had very favorable performance, like Hospital C, they could actually get some additional money. We think it would strengthen the incentives for readmission. It would have the advantages of the shared savings program, which is you do a prospective offset at the beginning of the year, and you guarantee the savings that you're trying to target for all payers, regardless of hospital performance. And it provides a very, very strong incentive for the hospital year after year to reduce their readmissions, because those targets or those standards are being rolled forward. In the current case of the shared savings, it really doesn't, there's not as strong a set of incentives for hospitals to reduce their readmissions, because the scaling is very narrow, and also you're not rolling forward the hospital's performance in the context of the shared savings. So the idea was to try to combine the two and then simplify the Commission's policies with regard to readmission. The very last couple of things that I'll mention is that we still continue to believe that it's better to have a Medicare-specific target. We also want to throw out the idea, and I know time's short, and all of this may not be feasible to fit in this cycle, but of having a Medicaid and a Medicare target handled either separately along the lines of the way we've approached it. Although indigence, arguably, in the Medicare population or Medicaid population may be less relevant, and even potentially have a pooled Medicaid and Medicare target. Again, the idea being that Medicare is really where the action is, and that's where we have to meet our contractual obligation under the model agreement. So I'll stop there. I'm sorry I ran over.
Everyone did. No apologies necessary. Any questions, comments, Justin?
I have one question before I make comment, and it's the readmission-related revenue. Are you thinking it's the inpatient revenue or just the readmission component?
Just the readmission component for each hospital.
So I'll make a joint comment, I think, related to shared savings as well as to the methodology. Shared savings, I've mentioned this before, and so it's not a surprise that I think we have to look at the shared savings in context with the rewards of the readmission program. I think that you have to be careful offsetting too much through shared savings and not actually having a net reward to the folks that are high-performing readmission hospitals. If you're essentially offsetting the entirety of the reward, what have you really accomplished would be one point. And I think, Bob, if I'm reading this right, the way that you're just applying that to the readmission-related revenue, it really significantly reduces any rewards that you can generate. So much like when we're talking about the MHA policy, you said it had a bias towards the favorable. I think this would have a bias towards the negative or towards limited rewards. So I just think we need to recognize that and talk through it as we look at the.
It definitely does. It would be a bias to the negative. But again, it goes back to maybe what was in part the intention of the shared savings, which was for there to be a net offset across the industry. This just now widens out the ability to scale those adjustments in a more logical way, and also strengthening the incentives. And the other point I didn't mention is that you could then apply other factors as you're looking to do, like PQIs, or even potentially sepsis, or unnecessary procedures, if you can create a similar set of standards as we did with readmissions here, and then add those into this analysis as well. So yes, it is biased to negative, but I think that's by design with the shared savings program to begin with.
So we have 20 minutes, and we have a few more other things to go in terms of timing. I think first of all, I think these are two very distinct but also interesting proposals, I would say. And the question is, we probably need at least one more meeting to think these through and then come back and have more discussion for the 18. So I'm not sure right now how long it will take us to work through everything and finalize the recommendation. For sure, it's not going to be final for me, I think. Everybody in agreement? Yeah. Right, because right now staff is, I don't have any proposal for you to comment on, and I would hate you to see it on Wednesday and then try to figure out in a week what to do with it. So, so with that, I think we are going to push it to June, and I would like to take that, couple weeks to think these through, and then we can meet again in May. I think we have one scheduled already, right? So we could think about this, and then at that point, we need to make a decision whether we are ready to have the final in June, whatever we have, or that we need more time and work it over the summer.
Yeah, I would say regardless how this works out, this could be productive discussion.
Yes.
If it doesn't fit in for June, then
right.
You got a leg up for next year.
Thank you for bringing that out, because next year, strategic discussion, we had the rainbow slide that I presented last year. Maybe, for May meeting, we really have to have that discussion too. Are we committing ourselves to look at this from a broader perspective and change all 3 programs and then look at more service line specific measurement. And if you do it that way, then we need to think about how our readmission revisions are going to fit into that plan. So I think we have some thinking to do between now and that one. And ideally, I think we would like to have something finalized by June rather than dragging it over the summer. So the question about the timeliness and the impact would be helpful.
Just one point about the rainbow slide. It's very, very difficult for people like me that are colorblind.
Oh,
just as this chart was very difficult to sort out. So you could like ratchet up the gray scaling on.
Bob, I'm already working until midnight, so if I'm going to try to do that, I don't know when I'm going to sleep. Yeah, I noticed that before. I just don't have the support, frankly, to do all those, but I'll try to have someone assigned to it. So that's on the readmission one. I think we have some work to do. And I wanted to go through the shared savings a little bit, but just briefly, we've been looking at the sepsis. Could you change to our slide deck, please? Can I turn my slides to you so you can make it happen? Can I list that on your agenda?
PowerPoint. Go to PowerPoint. I'm sorry.
That's all right. Don't.
The other one. There. And now just.
Oh, I forgot about this. Why don't we talk quickly about the? Yes, because yeah, the 2 revisions that we are thinking about for the readmission measure itself.
Right. So very quickly, we are talking about changing the readmission measure for 2 exclusions, and we wanted input. First, our removal of rehabilitation cases. If you go to slideshow and then up there, yep, and then current slide. No, that's okay. I can.
Is it in the hard copy?
Hard copies. We are on.
That's okay. Here we are. Great. So first is removal of rehabilitation cases. We've had concerns about the plan logic, and we also know that there are ICD-10 issues around rehabilitation cases now grouping to the type of rehab that they are. We also have removed the rehabilitation cases from our CMMI measurement because they are nationally treated. They are nationally not in the data. The second issue that we've had are people talking about that oncology cases and concerns over whether the planned logic is properly accounting for these cases and whether the complexity of care for these patients, whether a lot of the readmissions really are not preventable. So quickly, we just looked at what would be the calendar year 13 base period rates with or without rehab. So on the x-axis you have it including rehab, on the y-axis you have excluding rehab. Really this only makes a difference for Kernan or ortho rehab. I don't know what its official name is. I apologize. So all other hospitals, their rates really aren't impacted. In terms of improvement, looking at calendar year 13 to 15, again, there's a real impact for Umroy where, they look like when you include rehab, there's almost a 7% increase in their readmission rate, and when you remove it, it is about an 8% improvement in their readmission rate. And then there's some impact on a little bit on the other end where Laurel gets worse when you remove the rehab cases. And so, again, we're trying to make a decision both for fiscal year 17 and 18 on how to handle the rehab cases, especially given the ICD-10 issues. Next, looking at oncology, the numbers in the chart just tell you how many oncology discharges we're talking about here. It would be about 12,000 discharges. Again, when you look at the case mix adjusted rates with and without the oncology, there's very little impact of removing the cases. And again, when you look at the change, there isn't a huge impact, but there are some individual hospitals that have an impact. So for instance, Garrett County
they had a improvement in their readmission rate of 1.25%. When you remove the oncology, that increases to 4.4%. And Montgomery General, too, you can see the improvement goes up a bit when you remove these cases.
So I think for the rehab, it's kind of clear to us. It's about the planned logic issues, a little bit oncology. This might be a temporary fix until we figure out how to define the planned algorithm appropriately. If you look at the readmission rates on slide 29, they do have higher readmission rates, and we think some of it is because planned, but some of it is definitely preventable. So we don't, we may want to put this as a temporary fix, and then work. We already are engaged with the CMS algorithm, but work that a little bit and define and try to include oncology patients in.
Any comments on this? Okay. Turn it over to you.
All right. So the percentage risk slide, I just put it up there in terms of thinking about the penalties and the rewards. There is no change currently. So these are from last year. We don't think that we need to change any of these numbers for this year. Obviously, it depends on what we are doing with the readmission a little bit. And then the you've seen these before compared to the national benchmark on slide 33 for 17. So here the kind of asterisks on the top for Maryland, we are not sure what the shared savings number is yet. That's going to be a commission vote on what the number is. And then the GBRPU adjustments is calculation, and we don't have that number yet. If you just take them from the last year, our potential at risk for 17 is at 9.26%, and then the comparative number for the national is at 6%. So this is, remind you, potential at risk, and we are way above the cumulatively the national numbers. The other test that we have is looking at actually what the impact is on the hospital rates, the realized at risk. So our 3% at risk on MHAC, as you know, is reduced if statewide we do a good job, right? It reduced from 3 to 1%. And then since we use preset scaling, that 1% penalty may not apply to any of the hospitals. So once you look at the actual reductions or improvement penalties, this is the average adjustments done for each program. So for MHAC, for 2017, this is a preliminary number, the average adjustment plus or minus is at 0.6%. So this is across all the hospitals. Some hospitals are getting positive, some negative, and some getting 0. And the comparative number on the HAC for the Medicare program is at 0.22%. So for the RIP right now, it is about 0.4%. So when we add these averages together, you see that the numbers are much closer to the national realized at risk. So we need to watch both those numbers when we think about the aggregate at risk policy. Any quick questions on this? All right. These are the preliminary estimates on the impact. So by May, hopefully we'll have numbers for the QBR and others, some preliminary numbers. But in general, the MHAC scale is producing 30 million positive adjustment overall for the statewide. We have only a few hospitals, two hospitals, one right now, one hospital getting this penalty, and the rewards are about 31 million statewide. And for the readmission, the existing current one is producing 28 million net adjustments with 37 million total penalties and 9 million for rewards. So in terms of the shared savings, we want to discuss with you about the measurement of the shared savings and payment work group. The number for the adjustment itself is going to be also discussed in the payment work group, how much money we want to put in the shared savings. But obviously, they are interrelated, so I think it's fair to say the same discussion is going to happen in both work groups for the shared savings. As you know, we've been discussing the sepsis issue. I'll just go through for the speed issue. So we pulled the HCAP data to look at our sepsis rate compared to the national estimate to see if we have higher sepsis rates or not on an all-payer basis. So what you have is the pneumonia and sepsis, and we are concerned, as you know, with the relationship between the two DRGs. What you have is for the national and Maryland comparison, we have 2% pneumonia cases in 2013, and the national estimate is at 2.5%. So we have slightly lower percent of pneumonia cases in 2013. And then what you see is we have slightly higher sepsis cases compared to the national estimate, so 3.6 versus 3.9. Unfortunately, there is no national data for the trending. So for the 2015, what you see is that pneumonia cases didn't change as a percent, but there is a big increase in the sepsis cases. And so we discussed the sepsis issue and how it is hard to define as potentially avoidable. What is the source? So we are looking into other ways of looking at expanding the PAU definition. And one, Diane's been working on this one, and maybe she could explain it a little bit.
I'll be real brief. So the Prometheus potentially avoidable complication methodology, it is endorsed by the NQF, and it looks at 6 chronic conditions, and over a year span, patients have to be between 18 and 65, and it includes hospitalizations as well as ancillary and ED visits in the calculation. And so these potentially avoidable complication events are ones that are not defined as, quote, typical for that disease or a chronic condition, and therefore major infections such as sepsis, DVT, adverse drug events, and other safety events are defined as potentially avoidable, whether they're, quote, present on admission or not. And they did have 4.7 million covered lives in this analysis, and again, it was encounters over a year period. So I think we have to be open to looking at other methodologies like this that are rather broadly in use to see what we can adopt here.
So if you just think about the sepsis cases, right? We said we can't really know what is the proportion of avoidable on all the sepsis cases, and this methodology first defines the population of patients and then assess whether those sepsis cases are avoidable. So, you know, it will narrow down the potentially avoidable sepsis cases. I mean, sepsis is one example. They have other things too, but this is a different way of looking at the avoidable utilization from more condition-specific or patient-specific measurement type.
I just have a quick question. I think nationally, specifically in Kaiser Permanente, we put together a lot of protocols to identify sepsis cases earlier in order to make sure we're identifying them and treating them early to avoid complications. And I'm a little bit worried that our intent of diagnosing and treating and better outcomes overall is counterproductive to this, because we're admitting patients with sepsis because we have these new workflows through.
Right, and there's a collaborative, there are 21 hospitals in it, there are 2 cohorts, 10 in the first one, 11 in the second, and they're doing exactly the same thing, working on early identification, trying to reduce, putting in care protocols and trying to reduce mortality. So we are acutely aware, and we want to look at these early adopter hospitals, and if their patterns of sepsis identification are different, to see what implications that has for our measurement.
Right, so then, you know, overall our perspective is, yes, we want to support those efforts at the hospital. So what are the things we need to do to prevent them, right? So, and are there things we could measure to help you guide that? So we are sensitive, so we are not right now putting sepsis in, but we want to have this conversation and find a way to lower our sepsis rates, right, without impacting, without impacting those processes that are helping patients. But what are the things we could do to reduce the sepsis cases to begin with?
So I understand that. I think the challenge is we can't start reducing until we know what the true baseline is. And the problem is, I think nationwide, there is undercoding for sepsis, and there's not early recognition of sepsis. And so if we're, on the one hand, we're trying to recognize sepsis earlier, code for it better,
right.
I don't know what the baseline is to then say, okay, we need to reduce. So I think eventually, absolutely, we need to reduce it. But I think we first need to establish the baseline.
Yeah. Okay. Yeah. So I'm not going to go through it, but in the last presentation, we provided some trends, and Ed had a comment about just putting the actual case counts in addition to the ECMATs. So here is kind of a big table. We'll get back to this again, but on the first one is the non-PAU volume, so it's the number of cases. So we added the observation cases in, so we have about 550,000 cases in the state that are not defined as PAU for now. And you see that they declined by 2% in 2015 on an all-payer basis. If you case mix adjust this, the decline is at 0.69%. And then what you have is the total charges for these cases. So I'm going to go down to the PAU then. So on the PAU side, on the case count, we have 1.6% decline in 2015. When you case mix adjust, it's about 0.3%. And majority of that is coming from readmissions, as we kind of know already, that the readmissions declined by 3.7%. But the PQIs are increasing in 2015. And as we are thinking about the model in reducing avoidable utilization, last year in the shared savings discussions, we wanted to keep it at readmissions because we weren't improving as fast on the readmissions. And this year's is opposite, that we did great on the readmission, and thanks to the hospital's efforts, and also I think because we kept the policy focus on the readmissions. And the staff perspective now is to broaden the focus and include PQIs in the shared savings adjustments. So more focus would also be diverted to the PQIs. And also, I recognize it is a harder job to do the PQI reductions compared to the readmissions. So that's kind of the trend issues. And I'm going to skip this. We'll come back to it. But in general, all this analysis, we're working on the ICD-10 impact. We identified rehab already. There's a meeting coming up. So, you know, that's kind of on our agenda to look at the ICD-10 impact on all the programs. So I will stop there. So lastly, on the shared savings, the addition of the PQI, this long, nicely done. Thank you, Kim. This is always nice. I'm getting old too. I can't see the small numbers. But so here what you have is the percent revenue. If you move the shared savings to a PQI and the readmission, what you have is the trend for 2013, 14, and 15, and then the percent revenue for PQI readmissions in total. So sepsis we would like to discuss further. We may want to look at the Prometheus model, continue to that discussion, but given the timelines, we think that we need to do PQIs and readmissions only. And here are the kind of statistics for percent PQI and percent readmission if you do the PAU adjustments in total. So this is sorted by the percent revenue of PAU, the red numbers. So Kernan Rehab Ortho has the lowest PAU given their patient mix. I think this is not as unexpected. And then what we have is the Dorchester having the highest PAU with the 20% of their revenue in PQIs and readmissions. And when you look at their numbers, it's kind of both of them are high. And I think what also I wanted to point out is the readmission percents here are readmissions coming to the hospital. So they are going to be different than the risk-adjusted, our improvement goals. So shared savings is about the global budgets, right? We are expecting hospitals to reduce potentially avoidable utilization at their hospitals to generate revenues. So the opportunity for a hospital to function under global budget is dependent on how many avoidable utilization they have at their own hospital. So if you are reducing readmission in another hospital, that is not savings to the originating hospital. So readmission reduction program is holding hospitals accountable for their own readmission rate, right? Index, right? So if the patient comes to me, it comes to Mercy, we're looking at their readmission rate for all other hospitals in the readmission program. But then Mercy, is getting readmissions from other hospitals too, right? So in terms of the global budget mechanism, if you think about it, Mercy may reduce their readmissions to everybody, so they're going to benefit in the readmission reduction program for that effort. But if their 50% of readmissions are coming from other hospitals, their impact is not going to make in the global budget because their readmissions are happening in other hospitals. They are not saving on the global budget for that. So this one is now saying on the potential avoidable, think about the definition, it's coming to your hospital from other sources. Our PQIs are linked to the ambulatory care. Admissions here is coming to your hospital. So when you look at the rates, that's why, for example, the readmission rate here for Kernan is at 0.5, right? But Kernan's own readmission rate is much higher because their patients are admitted to other acute hospitals. So I think we want to have that discussion too, and I just want to point that out that shared savings is kind of savings under global budgets, what opportunity a hospital has, and what is the prospective adjustment that we would like to make to ensure that the global budgets are functioning.
I want to make sure I understand beyond the concept. So the readmission count here for the numerator, those are not index admissions, they're just the readmissions?
Yes.
And they're the readmissions that occur either at your own?
No.
So this is where I'm stuck.
All right, so let's say Mercy and University of Maryland, right? Patient is admitted to Mercy and then readmitted to Maryland.
Okay.
So that readmission is at Maryland is at Maryland's percent here.
Okay.
But the readmission for Mercy is at the readmission reduction program because there we are saying this is Mercy's readmission rate no matter where the patients are going. Whereas in the shared savings, these are the readmissions happening at your hospital where if you reduce them collaboratively, you're going to save under global budget. If Mercy reduces their readmission and prevents the University of Maryland's readmission, it's savings to University of Maryland, not to Mercy. So the savings in the readmission is under global budgets are different than the actual readmission rates.
I think I understand the idea is we're looking at, we don't care where the index admission happens. We only care where the readmission happens.
Right.
So any of the readmissions that are at a particular hospital, that's what's in the numerator.
Right.
And then the denominator is still the full complement of
Mercy's.
Of Mercy's
right
cases.
So readmissions happening at Mercy versus readmission, all admissions, or in this case, total revenue of the Mercy. So I think if you think about the Kernan, I think that will help in terms of why why there are two different readmission numbers. Because Kernan, their readmissions are happening other places. and there's not many readmissions that they are receiving because all of them are all planned rehab. Yes. We would like to align the shared savings more with the global budget concept and the opportunity to save. Last year, we were trying to reduce the readmission rate, so we used attainment levels for the shared savings. So we are over a little bit, and I'm so sorry.
No, you're good. So I'll just mention, we don't need to go through the slides, I'll just mention that we're grateful to everyone who was on the subgroup who was updating the GVR infrastructure reporting template. We feel confident that it is an improvement over last year. We are working to have better financial data and analysis, better outcomes and performance metrics analysis, and better categorization, qualitative analysis for the commission when we present the infrastructure report to the commission at the next time. So we're very grateful to everybody who worked on the subgroup. We plan to send out our final memo and reporting template by the end of next week. And if you have questions on what you should be reporting, or if people in your hospital have questions on what they should be reporting, you can direct those towards me. But again, the report will be due the same time it was last year, 30 days, 3 months after the end of the state fiscal year.
Any departing comments? Everybody's hungry?
Yeah, the next meeting.
Thank you.
Oh, June?
There's no May.
No May? All right, I'll see you on May 18th. Thank you, everyone.
Okay, bye-bye.
Thanks. Bye. Bye.